Thank you, Jennifer, Ed, and Clemens for great talks there. So we're going to have a Q&A session here, and there's lots and lots of questions. Wow. How long have we got? So the first question is for Ed. Knowing that sugammadex can interfere with hormones such as birth control agents, do we need to avoid giving it during cesarean for concerns in terms of postpartum hormones and in relation to breastfeeding?
No. The women haven't been using birth control at that point, so we're okay there. But I think I think we have to remind women all the time, if they're not out of the obstetric suite, that they can't interfere with their birth control. So I think that's important. That's an important point to make. But for the pregnant woman, it's not an issue.
Okay. Jennifer, what about using VLDS very low dose spinal, for example, 5 milligrams bupivacaine with an EVE technique for short procedures like D&E, D&C? I'm not quite sure what an EVE technique is. Oh, okay. So using a very low dose spinal, such as 5 milligrams of bupivacaine, and then I guess extending the block with epidural volume extension.
I think that's what the main thing is. You want to get a high enough block. So you want to be at least T10, slightly a little bit above that. So if you can do that with the block, that's fine. The issue is really having enough time for them to do the procedure. So these procedures are fairly quick. You'll know your proceduralist and see how quick they are doing it, and then getting a high enough block. What you don't want to do is have a block that they're uncomfortable, and then you have to supplement with medication. So you're kind of doing now a combination IV technique with the spinal. So if the block is high enough to do it, that's fine. I think the bigger issue is having enough time and getting the block adequate enough and high enough.
So another question for Ed. Ed's got the majority of questions. Do you give Bicitra and Reglan for an awake C-section too, i.e. routinely?
No, we don't give Bicitra like for a spinal or an epidural anymore. We used to do that when I was a resident, and for several years afterwards, everybody got the butterscotch flavored Bicitra that our pharmacy made up that was awful. And it doesn't really make any sense if you look at the graph of how long it lasts. If you give it to them when they first get in the OR, and it takes time to actually get your spinal in, and by the time that you might have to intubate them during the case for a failed spinal or something, the effect of the Bicitra is gone. So you give it right before you're going to need it, because it only lasts, like we said, 15 minutes or so.
Clemens, do you think focus ultrasound is going to become mandatory for all OB providers?
I think it will become mandatory for our specialty. And I think we are getting into the direction that it will become part of our residency training. And as the material is getting more and more available, we might also come to a situation where people might ask you, when there was a complicated situation, why haven't you actually checked with an ultrasound? I think it's still a way to go, and we still have to define our training pathways, but I think it's a question of time until it will replace maybe the stethoscopes.
Okay. Ed, for you, in non-OB surgery, would you consider sugammadex for reversal of non-depolarizing versus neostigmine?
For non-OB surgery,
during pregnancy.
Oh, during pregnancy, using sugammadex. I would, yes. I don't know why. I'll be honest, I haven't used rocuronium at all for intubation in pregnant patients yet. I think I would use the Gamadex. I don't see an issue with it at this point. I mean, there could be hormonal effects that we're unaware of, but at this point, I don't know of any.
I mean, the effects are supposed to be reduction of progesterone, but there's so much progesterone being produced by the placenta, then I don't think it's an issue. We've used it. We haven't had any complications in our pregnant patients who are having non-obstetric surgery.
Jennifer, how about using opioids such as morphine or Dilaudid to avoid the potential risk of a spinal headache in a grieving mother?
So I wouldn't use opioids alone I'm assuming we're doing an induction termination.
Yeah,
Is that
yeah,
okay?
Yeah.
So we will start with Dilaudid early on in the induction. And usually, as I mentioned, patients will try to get by with just IV morphine, maybe fentanyl, to start, and then we can give them, we've done Dilaudid PCAs, but eventually, I would say the majority of our patients end up having an epidural, and we would do our epidural technique how we would do it with a laboring epidural. So some of us do CSEs, some of us do straight epidurals. I think a few of us do DPEs. So it's the provider preference with the idea that we're able to get a better analgesic control for them while they're laboring.
So all the rest of the questions are about general anesthesia related topics. So I'll open it up to all three panelists, not just Ed. So in an emergency C-section, would you have the obstetrician scrubbed and the patient prepped and draped and the urinary catheter inserted before you induce general anesthesia?
That's our standard, is that you want to minimize the amount of time from induction to delivery so that you limit the exposure of anesthetics to the baby, and that's how we practice.
And in terms of uterine displacement...
It's fine. I was just going to say, we do the exact same thing, which we have them prepped and draped, and And I was going to say, usually because if we're doing it as an emergency C-section, obviously we want to be able to deliver the baby as soon as possible, but you also, any anesthetic effect is also going to affect blood pressure of mom, and you want to minimize adding that as a complication to an already compromised fetus.
So in terms of uterine displacement, is it equivalent left versus right? Clemens, do you want to say?
No, it's not equivalent because you need to displace the patient to the left side so that you improve your window. And if you place the patient to the right, actually you make your imaging acquisition much more difficult.
Yeah, I think the MRI studies have shown that it's really the vena cava that collapses, not the aorta, and so that you really need to get the baby off the vena cava. The caveat to that is sometimes with breech presentations, you do have to use right uterine displacement for some reason. I don't quite understand, but the patients will actually do better that way. But, and that's the rare breech presentation that it's like that. The key is to use left uterine displacement.
So in terms of pre-oxygenation, so comparing 3 minutes versus 4 or 8 maximal breaths, in terms of the time to quicker desaturation, how does the 4 maximal capacity breaths compare to 3 minutes in terms of desaturation?
In terms of desaturation, I actually took that slide out that I show usually, but it's exactly the same. Mark Norris did this study long ago, and they actually had art lines in, and they looked at arterial partial pressures of oxygen in the moms and also in the cord gases, and then they looked at before and after induction. And 4 breaths versus 3 minutes, it was exactly the same. And so the good news is because of the low FRC, which is a problem in terms of desaturating quickly, in terms of washing out the nitrogen, it makes it much easier.
So Ed, you mentioned about a head of the bed being up to aid intubation, but does that also increase the FRC?
It will increase the FRC, but you know, the key is to get the tube in the right place. And so, you know, that obviously that position and that picture the woman is in, that will decrease the FRC a little bit, but you know, get the tube in and then your problems are solved.
So for the next question, I guess we can each hear from each panelist from their institutions, and Clemens from Vienna. What do you suggest for a pre-induction briefing before C-section undergoing GA? And do you mean in terms of the safety huddle before the induction of anesthesia for the whole OR, I presume? So how do you instruct the room that you're going to be doing a GA? Or what briefing do you give the rest of the staff in the OR? Do you do that at all?
I can start. So once we're rolling in with, oftentimes it's a fetal deceleration, we actually will put the baby on the monitor, and we have the obstetrician actually tell us if we're going to pause, if the heart rate's back up, or if we're going to proceed because the heart rate's back down and we're moving to a emergent delivery. So at that point, that's our moment of pause. And when we are instructed that we're going to do a general, then there is a little bit of, to be honest, chaos at that point as we're moving over and getting everything set up. The moment that we're ready to induce, though, the obstetricians, at that point, they've splashed the belly and they're gloved and draped. And we actually say, we are ready to induce, and then we have them give us the affirmative that they've told us. And then we will actually one more time alert that quiet in the room, and then we actually say we're inducing. And then there is a process where they have to wait for the attending anesthesiologist to look the attending obstetrician in the eye and say, once the tube is in and we've confirmed, we actually say, you may cut. And that's the part where I think in that entire room, we've been very good at people being quiet during that key moment.
Yeah, in Vienna, our practice is, of course, a little bit different. We have very well-trained anesthesia nurses, but in Austria they are not allowed to provide anesthesia. They are more your second pair of hands. And so we have dedicated anesthesia nurses in the labor and delivery environment. And actually we have also 2 labor and delivery rooms that are equipped with anesthesia machines, so that even emergency C-sections are done in this labor and delivery room. And the problem is never to get the oxygen there, because it's the first thing that the anesthesia nurses and whatever we do is put them on a mask. The main challenge is actually always to take the time when everybody is very nervous to position the patient optimally. That's very often the main challenge. But the pre-oxygenation is, I think there's always this time to give the patient these 4 or 8 breaths.
Yeah. I do think it's a good idea to formalize it like they have at UCSF. I have to say we're more informal, but the key is communication. And I think formalizing it does solve the occasional problem.
So Ed, you mentioned that you don't always use cricoid pressure, and it can be a very hot topic of discussion. If there was a bad outcome in a patient who had not had cricoid pressure applied, could that be criticized by an expert witness?
Yes, it can always be criticized by an expert witness. I think at this juncture, though, there would be some very prominent OB anesthesiologists and general anesthesiologists that would be more than willing to defend you in court, and basically say that the standard for cricoid pressure is now very debatable, and to not use it is defensible, in my opinion, at this point.
Jennifer and Clemens, what's your clinical practice in terms of applying cricoid pressure or not?
It's also always debated. I think I do not routinely provide it anymore.
Okay, Jennifer?
We do cricoid pressure, but again, when we look, if we're struggling, we're gonna make adjustments, and if it's impeding in our view, we'll let go of it and proceed. But we start with cricoid.
Yeah, I actually know lots of people who are at the point where they kind of confess, I do it. I say I do it, but I don't push as hard. I don't push hard because I don't want to induce any retching, and I'm let up really easily on it. So I think de facto, a lot of people are not doing it, but they're kind of like going through the motions to say they are for medical legal reasons, which I don't think is really necessary. I think we need to just, stand up and say we're not using it anymore, because I do think it causes more problems than it solves.
And just one last question on paper, unless anyone else has got any more questions they want to just ask verbally. Ed, what are your thoughts, or anyone, what are your thoughts on withholding Bicitra in asymptomatic patients due to concerns of actually causing nausea and increasing the gastric volume? And could that potentially have medical legal implications?
Well, in terms of medical legal, complications, it is the standard of care. So, people will completely defend you on giving Bicitra for medical legal reasons. So you don't have to worry about that. And a lot of things in terms of medical legal reasons, we always say that. But if you're practicing good standard medicine, you will be defended for that. In terms of increasing the gastric volume and making patients nauseous, well, at that point, when they get nauseous, they're awake and they're guarding their airway, so that's not really the issue. In terms of increasing the volume, I guess, yes, you are, but now it won't do nearly as much harm if there is some reflux. But for the most part, that small increase in volume isn't going to matter.
So we do have a few minutes left, so if anybody has any burning questions they want to ask, stand up and ask them, or we can finish early and... Okay.
Mm-hmm. Like this giant tegular that pulls the abdomen in. Everything is from the neck up to the chin. And that's the position they're in peptin when we're trying to induce general.
I really feel fortunate to live where I do because, everybody has to work so hard and you can't afford to buy a lot of food to get too fat. No, but we don't really have as many obese patients. We once did a study on looking at the ED95 of local anesthetics in obese patients. It took us 2 years to recruit 40 patients over a BMI of 40. Yeah, so sorry about that. But I think this is where video laryngoscopy is going to save you. I did once have an obese patient that was, taped up like that and had the spinal not work, and then we had a CSE, but then the epidural part didn't work, and we had to put her to sleep. And she was typed up, had the belly open. It was a horrendous situation. And I just used the glide scope and had a perfect view. And I think this is where video laryngoscopy is really useful. And in fact, there was a great editorial in the BJA saying it's almost making, awake fiber optic obsolete. Which I wouldn't say that, but that's what the editorial did. But it is true that you can handle many of these situations with video laryngoscopy.
I guess it's a different patient population at Stanford than UCSF, but we do have a fair bit of high BMI patients, and they do use the Troxy. I think two things that can be a problem, and we discussed this. with the obstetric team is they're putting a lot of weight, and so if you're having to do general anesthesia, sometimes ventilation is a problem with that positioning, and so we just let them know that what we would potentially do if that's the case is we would lift up a little bit with the back of the head up, and so the patient's tilted a little bit, but we do it in such a way that we kind of check it ahead of time so that they can operate and we're still feeling like we could ventilate enough. And then we use the video laryngoscopy for those cases. I think most of the patients, if we're doing a crash, we sort of moved to this doing video laryngoscopy for those patients, in particular patients that are obese and are severe pre-E patients. If we're going to do a general anesthesia, that we're doing the video laryngoscopy, and it helps. There have been a few patients that I was concerned enough with their BMI. I think 2 in particular had BMIs of 90 and one that had a BMI of 75 that I actually just did an elective awake fiber because I was worried about the ventilation issue of them and that weight that they would put on if I had to level them out. So,
Good question. Any other questions? Okay, well, thank you, Jennifer, Ed, and Clemens for great presentations, and we'll break now and resume at 10:30.